And I'll be talking on the surgical solutions in ROP, the timing, techniques, and the outcomes. So straight away going to the timing. Now this slide shows the natural history of a typical ROP at whatever gestational age the child is born. We start ROP screening by around 31 weeks of post-conceptual age, because that is where the proliferative or the phase 2 ROP begins. Around 35 to 37 weeks is when we expect the high risk pre-threshold or the threshold ROP to develop. And beyond that, it will either regress and progress. So the ideal timing of surgery is after the due date, which is usually at around 42 to 45 weeks. And why is that? Because that is the time when the VEGF levels are increasing, when the TGF beta levels are and VEGF is decreasing, the TGF beta levels are increasing. So that is where the traction is going to, really shoot up after that. And that is the ideal time when you should plan for a surgery. And 4A, 4B are of course, and stage 5. Stage 5, I think, will be taken by Dr. Pramod in the next talk. So I'll be talking mainly on 4A and 4B, and not all 4A and 4B require surgery, only if they are vascularly active, if there is a risk of progression to to the subsequent stages. And the 4A, if there is more than 3 clock hours, then only you should plan for a surgery. Now, vitrectomy for ROP is still one of the most challenging problems facing the vitreoretinal surgeons, and frankly, I think it is the other way around. It is one of the easiest to tackle if done carefully and properly, and the outcomes can be excellent if you follow this. So why pediatric retina vitrectomy is difficult in ROP? It's because the altered anatomy. Axial length is extremely less. It's around 16 to 16.5 millimeter compared to the adults of 24. The vitreous volume is around 1.5 ml. The ciliary body is flat. There is no pars plana, and there is actually a pars plicata. So the anterior is the entry has to be very anterior to the pars plicata. Other thing is that the lens occupies a large portion of the posterior segment, unlike adults, which is around 10 to 15%. In the pediatric age group, in an infant, it will be as much as almost 25% of the space occupied by the lens. And so this restricts the intraocular manipulation and increases the risk of mechanical damage to the lens and also to the retina, which is anteriorly displaced because of the detachment. So RD in RO, the retinal detachment in ROP is basically a majority of the times a fractional retinal detachment that we must understand. And the goal for our surgery in ROP is to reduce or remove the traction. If it becomes a rhegmatogenous retinal detachment with a break, then sadly it is the end of the story and nothing much can be done because the vitreous is so adherent, it is almost impossible to flatten the retina. So surgical options for stage 4 are scleral buckle, which is mainly for when the traction is very peripheral, and the lens sparing vitrectomy when there is a posterior traction or there is enough space between the lens and the retina where you can insert your instruments and do a lens sparing vitrectomy. Now, why the buckle is easier than an adult buckle? It's because you don't require a large band, just the smallest, the number 240 band, which is around 2.5 millimeter. There is no localization or cryo required because this is a purely fractional retinal detachment, not a rhegmatogenous one. There is no need for any subretinal fluid drainage again. There is no tire required where you require a tire for a segmental thing. Usually you don't require in ROP. No sutures, we use only tunnels. So it's a sort of a sutureless surgery. And there is no posterior placement because the traction is very anterior. Just at the base of the recti muscle is where you would want to place the band, and that is why it becomes easier. And this is one of the cases which is an ideal for a buccal. You can see this is the right eye and the left eye, the posterior pole in the peripheral. There's a very peripheral traction there, temporal in the right eye and the left eye. It is impossible for the instruments to be inserted inside without damaging the lens. So these are the ideal cases for scleral buccal surgery. The disadvantage of sclera, although the anatomical outcome can be superior to the natural history, it does not provide as good as visual outcome results because of the induced anisometropia and amblyopia. If it almost from -5 to -9 diopters, it can induce a myopia, and if the other eye is not operated, it will definitely go for amblyopia management. And second thing, it's a two-step surgery. You require additional surgery to remove the buckle for the eye to grow, which varies at any time from between 3 to 6 months, and some people even remove it at the end of 1 year. But it needs to be removed once you place a buckle, and it's a sort of it does not directly deal the vitreous traction because it's an external surgery. So it just reduces the traction, but you can't really remove it. So lens sparing vitrectomy is a preferred option nowadays. And because of the improved instrumentation, it has become very nice and easy to perform these surgeries. And but the traction has to be posterior, or there should be enough space for instruments to be entered inside the vitreous cavity without damaging the retina and the lens. So how this vitrectomy is easy in these babies is because what you the goal of the vitrectomy in ROP is just do a good core vitrectomy, and the whole aim is to tackle the traction bands, the various traction bands which are there, the lens to ridge, the ridge to periphery, and the ridge to this. This is what you have to do. The whole idea is to do a good core vitrectomy and come out. There is no need for PVD induction. In fact, you can cause more damage, and there is no need for vitreous-based shaving. Basically, you just require a good core vitrectomy. And why is it difficult? Obviously, it's because of the space constraint. Like I said, the axial length is small. The lens is occupying a larger space. And on top of that, the retina is anteriorly displaced. So it becomes very tricky. That's why you have to be very careful while doing this surgery. And that is why, like I said, there is no pars plana, it's actually pars plicata. So this is where you have to enter the pars plana region for the ROP surgeries, be it injections or even for vitrectomy. It is around 1 to 1.5 millimeter from the limbus. And as the age grows, only after the age of 7 years, you can safely go and use the adult dimensions. For ROP, it is this around 1 to 1.5 millimeter. Preoperative evaluation is extremely important. Anesthesia fitness is you require fitness to do the perform the surgery, obviously, because you require a good pediatric anesthesiologist. And if you're operating in an eye hospital like ours, you require an ICU backup because it's very dicey to keep these children post-operatively after a long GA. And then it is always better to shift to a adjoining NICU where they can have a proper people to tackle the situations. Education of the parents for visual expectations. You can expect to tell them that the 4A ROP, if it is successful, it can have fairly good visual outcome. When it comes to 4B and 4 and the 5, you have to tell them that it's not that the child is going to get a completely flat retina and is going to have a normal vision, or at the most, you can expect as an ambulatory vision. Pre-op B scan also is extremely important because it can actually show you the hidden traction bands which will be totally missed clinically in a case of stage 4A and 4B, and you will get a better idea of where to expect and how to tackle these traction bands. Always before scrubbing in when the child is induced under general anesthesia, take this opportunity to do a good indirect ophthalmoscopy 360 degrees. So you'll know the anatomy of how the detachment is there. And this can, help you plan where are you going to put your infusion cannula and where are you going to put your vitrectomy, the other two cannulas, other two sites. Because it can vary because sometimes, most of the time, the detachment is very high temporally. So you might have to go nasally and do the surgery. And the rule of the thumb is even if it's a stage 4A or 4B, if you see avascular retina, you have to first ablate uh, and doing a good laser. And it's always better before you go inside with the instruments to finish the laser of the avascular retina using a laser indirect ophthalmoscope because intraocularly the manipulation is very tricky because of the tight space and you can end up having a lot of complications. So always better to finish the LIO laser and then you go for the vitrectomy. Now it has gone from 20 gauge what we used to use, then we moved on to 23 gauge, 25 gauge, and 27 gauge. This may all look very flashy, but what you need to understand that the basic steps and it's similar in all whatever gauge you use. The only difference is for 20 gauge and 23 gauge, it is a transcleral, so you have to do a peritomy. Whereas a 25 and 27 gauge, it is a transconjunctival vitrectomy. But the principle is the same. 1 to 1.5 millimeter from the limbus, you go inside, just tackle the anterior and the posterior vitreous traction as much as possible. The one of the thing is that less is more. Don't try to be too aggressive like you do in an adult, like a diabetic vitrectomy. Just make sure that you come out and cut enough of the traction band so that the retina flattens down, and actually there is no need for doing any heroic thing like a PVD induction or a vitreous based shaving. And always putting a suture is a good thing because you want to, even if it's a 27 gauge or 25 gauge, because what you want to avoid is a post-op hypotony and a hemorrhage which can happen and which can actually lead to a disastrous outcome later on. So, like I said, this is a modified version of the vitrectomy which we have published years back. The instruments which are there for the 25 and 27 is for the adults. So, how do you reduce the height of the trocar and the cannula intraocularly? So, this is a 42 band which we cut in two small strips of 2 millimeters, and we cut into cubes by 2 by 2 millimeters, and we pass the trocar and the cannula through it. So, what happens is that it forms as a cushion outside the eye, and it reduces the intraocular entry of the cannula and the trocar. So it protects the lens and it protects the retina also from being punctured by your long trocars. The trocars are almost 11, so it reduces the height by almost 7.75 to 1 millimeter, which is quite good enough to do a safe surgery without damaging the lens and the uh, retina. So you can see all the three ports we have put through the spacer, and once you put the spacer, you can go inside and you can carry on with your vitrectomy, and anterior vitreous traction also can. So this is what we routinely use nowadays. These are the pictures of the pre and the post-op. Like I said, you have to do a good core vitrectomy. There is no need for you to remove the posterior traction bands, and it becomes quite good if you just leave it, and it flattens, and a good visual outcome also is predicted. This is the stage 4B. Like I said, 4B, don't expect it. I mean, don't tell the parent it's going to be a normal flat retina. The whole idea of the ROP surgery is to keep it as what it was and not to make it worse. So 4B will always remain a 4B. And probably we have just arrested this child from going to stage 5 ROP, and this child probably will have a little bit of ambulatory vision. This is a 27 gauge. These are very good instruments, very small, and you can, even if there's very anterior traction, you can easily go and cut the vitreous, the peripheral traction. But again, these are very flimsy instruments. You have to be careful. Sometimes they just bend inside the eye, but it is a good option now. 27 gauge vitrectomy. The causes of failure are usually the post-op hemorrhage. Like I said, it's always better to suture these sclerotic, even if it's a small gauge like a 23 gauge. Retinal breaks, if it happens, you're converting a tractional detachment to rhegmatogenous, then it's a end of the story. Inadequate release of traction. Now, this is a case you can see the very vascularly active treatment, naive stage 4A ROP, and it was all pulled temporarily. So we went through the all nasal vitrectomy, but unfortunately, at 2 weeks follow up, the traction was still there, and this I don't know if the picture is clear, but this nasal retina is pulled temporarily because of the inadequate traction band removal, and you can see the traction there. So sometimes it becomes very tricky and very dicey because it's a high risk surgery because the anesthetist also wants you to finish fast, and sometimes you have to sometimes you just come out fast and you lead out some of the unnecessary traction. So in our experience, a little older publication, what we had published more than 10 years back, around 33 eyes or 29 babies, and the surgical outcome is always good for anatomical success for 4A. It is anywhere between 90 to even 100%. 4B is around 50%, and stage 5 is poorer because of the anatomy of the disease and the very bad detachment which happens after for a stage 5 ROP. Trichode assisted vitrectomy is actually quite good. We used to use it quite often earlier, and we have stopped in between because it can cause raise in IOP. But then I feel if we dilute it enough, it is a good tool because the whole idea is to delaminate the posterior vitreous, and it gives an excellent contrast inside the eye. And this is one of the papers which we had published years back. This was a sort of a concentrated trichode, and you can see how it coats the posterior hyaloid. I mean, it can be a vitreous schisis also. You can actually do a better job using the trichode inside and cut the vitreous and going quite close to it. And this is where with the pick where I'm trying to induce a posterior vitreous detachment. You have to be extremely careful, and the traction has to be a very slow traction. And unlike in adults, when when you get the space between the posterior and the retina, you can just pull and it comes out like a entire V-ring. Here it is not like that. It is attached very adherently to the traction bands, and you can actually cause a break. So try to remove as much as possible with it, and then you need to stop it and just continue the whatever vitreous is there, trim it and come out. So that should be the end of the surgery. Now there are many scenarios like we said, ROP is sort of a bilateral symmetrical disease. And that is what Dr. Manvi had said, that we give bilateral injection at the same time, where, in ophthalmology, we don't want to do that because of the risk of endophthalmitis. Now, what happens if you get a bilateral stage 4 and 4B ROP? You just can't do a one eye surgery and say after 1 week or 2 weeks, I'll take the other eye, because the risk of anesthesia is there. And obviously, this is not going to remain like this. It's going to progress within a week or 10 days. This is going to close and become a stage 5 ROP. So what we had done and what we routinely do is a bilateral simultaneous vitrectomy. With a sequential vitrectomy at the same time, we operate both the eyes, and we do it in the same way, in the sense that we treat the other eye as if we are operating in a new patient. That means we re-scrub, we change all the instruments, put new set of vitrectomy instruments, and then do the other eye also, but in the same sitting. And in a paper, we had shown that it has a success of almost 100% for 4A and 90% for 4B, and none of the eyes any develop any signs of any infection. So you can take the risk, but you can explain to the parents and do a meticulous drop, and usually you don't end up with any complications. So again, this is a bilateral vitrectomy. This is a pre-op and this is a post-op, where the outcome was fairly good. And again, this is the right eye, left eye, the nasal traction, and the temporal ear. And this is the post-op pictures of the same baby. And we had published recently in the AIOS Times, along with my colleague Dr. Ratnesh, who's moved to Patna, who also does a similar thing here. And these are his images of a case which he did a bilateral simultaneous vitrectomy sequential at the same sitting. And at the 4-year follow-up, the child is doing extremely well and had a very good outcome. Again, role of anti-VEGF, we can use it to reduce the vascularity of the retina. So you can use it pre-operatively, intraoperatively, postoperatively, but you have to make sure that if you're using pre-operatively, kindly get a GA fitness first, because if you inject the eye and if the child does not get a GA fitness, you can actually worsen the disease, because there is always a chance of having a crunch phenomenon. And usually within 2 to 3 days, the child has to take in a first surgery. Intraop, it can also be used, can be used in treatment naive eyes. We have used that. However, like what I'm saying, we are not doing a complete vitrectomy here. You are leaving behind the vitreous, and you can still have a crunch phenomenon, because this is at the late stage of the disease, where you are injecting anti-VEGF. And we have had cases where, at 6 weeks post-op, the patients came up with the macular holes in both the eyes. And we were wondering, was it because of the inadequate fraction we had removed, natural progression of the disease, or was it because of the anti-VEGF which we give intraoperatively? So we don't know, but you have to be careful, and you have to be, you know, uh, you have to have this in the back of your mind that these things can happen. They have used post-op also, post-op vitreous hemorrhage, and it has also worked well. But this is all very small number of cases, and you have to just use anti-VEGF on a case-to-case basis. So in conclusion, vitrectomy for ROP can be extremely easy and can be a smooth sailing, but you must always remember that you are always at the edge of disaster. So just because you think it's going well, it's going to be easy, just a good chorectomy, don't think that you cannot have complication. Have all these things in the back of your mind, and you can actually have a successful surgery. So thank you very much.